So thank you very much, the organizers, for inviting me to present on this, I think, very interesting topic. Does doxycycline prophylaxis have a future in the context of biomedical prevention for sexually transmitted infections? The short answer is yes, and so I'm ready to entertain any questions. I have no relevant disclosures for this presentation. So I want to start off and remind people that antibiotic prophylaxis is not new. We use antibiotic prophylaxis for conditions like rheumatic fever, very commonly for travelers going to malaria endemic zones. We use antibiotic prophylaxis for certain indications to prevent endocarditis. We certainly are familiar with the widespread use of antibiotic prophylaxis to prevent pneumocystis pneumonia. It's been specifically reported the benefits of doxycycline as antibiotic prophylaxis for Lyme disease, leptospirosis, particularly used in the U.S. military when they go to leptospirosis endemic areas. It's also been reported successful to prevent scrub typhus, and it's often used by travelers to prevent travelers' diarrhea. So antibiotic prophylaxis is something that clinicians and patients are often quite familiar with, and they do understand the benefits of that. Doxycycline, some people mistakenly consider it a broad-spectrum antibiotic. Actually, it's often in the infectious disease world thought of as a narrow-spectrum antibiotic. It's not associated with C. difficile colitis because of that more narrow spectrum. It's one of our most inexpensive antibiotics and is generally well tolerated. And as people know, it's often used for months, if not years, for the treatment and prevention of acne in young adults. The pharmacology of doxycycline, if one uses 100 milligrams single dose daily, you get a steady state about 1 milligram per liter. The serum half-life is about 12 hours. The maximal concentration after a single 100 milligram dose is about 2 milligrams per liter, and that's relevant when we talk about the MIC for T. pallidum, the cause of syphilis. And steady state is achieved in about 5 days. The mechanism of action is what we call time-dependent killing. So like beta-lactam antibiotics, you need a prolonged period above a certain MIC level. But at higher doses, you can see what we call a dose-dependent killing, which is something more akin to antibiotics like ciprofloxacin. Now, the MIC for Treponema pallidum has been demonstrated in rabbit models with tetracycline at about 0.2 milligrams per liter. And the curve that I'm showing on this slide is essentially like a culture kill curve, and you can see when the tetracycline concentration reaches about 1 microgram per liter, you have a very high kill rate of T. pallidum. So with a steady state of 1 above an MIC of 0.2, you have what we call an inhibitory quotient of 5. And in infectious disease medicine, we usually like to see this ratio of at least 4. With certain intravenous antibiotics or injectable antibiotics, we can get very high ratios, but with oral antibiotics, as long as we're above 4 in terms of the ratio, we generally feel like we're going to have a high clinical efficacy. So specifically around syphilis, we're all familiar that syphilis has been increasing in men who have sex with men. It's associated with significant adverse health effects, including neurosyphilis and ocular syphilis, and it's associated with increased HIV transmission. And our campaigns, and this is an example of our well-known Healthy Penis campaign, while they're highly effective in increasing testing, their ability in terms of social marketing and media to actually control syphilis transmission is actually limited. So we do need alternative approaches to our campaigns and health promotion. So I'm going to review the 2 clinical studies and also an acceptability and modeling study on the data of doxycycline chemoprophylaxis for STI prevention, and in particular syphilis. So the first clinical trial was a randomized controlled trial that we did about 4 years ago now. It was a pilot study of 30 men. These 30 men were randomly assigned to a 100 milligram daily dose versus a behavioral intervention of contingency management, where we provided people a financial reward of $75 if they were STI free at their follow-up visit. The total study lasted for 48 weeks. It was led by Bob Bullen at the Los Angeles LGBT Center. Here you can see what the doxy blood levels were in the doxycycline arm participant, and on average they were above that level of about 1 milligram per ml or 1,000 nanograms per ml. There were a couple doses that were missing, and there were a couple people that had undetectable levels of doxycycline, as you might expect from non-adherence. But you can infer that those who were adherent had very nice, adequate levels of doxycycline on the single daily dose of 100 milligrams. And the main outcome of the study was a 73% reduction in syphilis. We also saw about a 70% reduction in any STI that was really driven by the reduction in chlamydia or syphilis. The second clinical study was reported by the IPRGAY study investigators at CROI in February 2017. And in this trial, they looked at on-demand post-exposure prophylaxis with doxycycline for men who had sex with men enrolled in their PrEP trial. And this was a randomized open-label trial. They enrolled HIV-negative high-risk MSM. They selected people who did not have any clinical contraindication to doxycycline. And the study design was on-demand PEP, or post-exposure prophylaxis with doxycycline, 200 milligrams single dose about 24 hours after sex, but may be taken up to 72 hours. And the comparison arm was people who were not provided with doxycycline. They were advised not to take more than 6 pills per week to limit antibiotic exposure, and the continued concern for selection of resistance. And they enrolled 276 patients, and they looked at people every 2 months and did serologic assays for HIV and syphilis, and PCRs for chlamydia, gonorrhea, and anal and throat swabs. So in terms of adverse events from this study, you can see that there was an increase of gastrointestinal-related adverse events in the doxycycline arm, with increase in nausea, vomiting, GI pain. But there was no difference really in any serious adverse events or any grade 3 or greater adverse events. And the conclusions from this trial were that PEP reduced with doxycycline reduced the overall incidence of STIs by about 47%. No effect on gonorrhea, which might be expected given the high prevalence of tetracycline resistance in Neisseria gonorrhea. But amazingly, a very similar effect size, 70 to 73% in chlamydia and syphilis incidence in terms of reduction. They concluded acceptable safety profile with mild to moderate GI adverse events, but that only led to discontinuation in 7% of participants. Their analysis of antibiotic resistance is pending, and their conclusion was that antibiotic prophylaxis for STIs based on these data is currently not recommended, and more research needs to be done. So the question is, what additional research needs to be done? And when WHO looks at making recommendations for different interventions, they often need to consider acceptability and modeling of the impact. So in preparation for a trial that we had planned underway in Australia, Australian colleagues led by David Wilson and others looked at a online sample of over 2,000 men who had sex with men to ask them about the acceptability of doxycycline for syphilis chemoprophylaxis. And if you look at the pie chart A, about 26% said they were very likely, an additional 26% said that they were slightly likely, to take doxycycline on a daily basis to reduce their personal chances of infection. However, when the question was asked if you would take daily doxycycline to reduce the rates of infection in the gay community overall, half said that they were very likely to take daily doxycycline, an additional 27%. So interestingly, overall, I would say moderate personal level acceptability, but when you looked at the potential for community impact, there was much greater acceptability. And the second aspect of the study, they looked at a model of the use effectiveness of doxycycline. If it's used by 50% of gay men, over what period of time would you expect a reduction in syphilis incidence? And they estimated about a 50% reduction in incidence in 12 months and 85% after about 10 years, and concluded that the majority of prevention efforts can be gained by targeting subpopulations of men with higher sexual activity. So I think it makes sense if we think about targeted chemoprophylaxis in certain subpopulations, maybe particularly high risk for new syphilis infection. So in summary, these two randomized controlled trials showed similar efficacy at 72%. They showed excellent safety, but admittedly relatively small sample sizes. The acceptability, I would conclude, was reasonable, and there's, I think, quite high promise for doxy chemoprophylaxis as a means for a biomedical approach to STI prevention. However, there are important concerns. Resistance keeps coming up as a barrier, so that actually led to the defunding of a trial that was on the tarmac or on the runway by the NIH. There were concerns about resistance for other pathogens, and the thought was, how could we fund a trial of antibiotic prophylaxis in this era of antimicrobial resistance? And particular concern is around Staph aureus, and doxycycline is one of our best agents to treat methicillin-resistant Staph aureus, particularly on an outpatient basis. Concerns about long-term safety. So how long do people need to be on doxycycline chemoprophylaxis? What are the long-term effects? What are the effects on the microbiome? And in an interesting editorial in response to our clinical trial published in STD in 2015, Matt Golden and Hunter Hansfield raised the issue of benefit. And what is the cost benefit? And if you're preventing STIs, something like syphilis, it's not the same as preventing something with a high mortality, potentially like endocarditis or malaria, and you're preventing something that's treatable. And is there a role for just the prevention of infection for something that can be readily detected with easy diagnostic assays? And then, most people will have a very successful result of treatment. But that kind of ignores what the community impact might be if you're just taking a focus on the individual benefit. They also raised questions at the time about the impact on the microbiome. That's still an unknown, and what long-term prophylaxis might impact there. But I might argue that we don't, stop us from using long-term doxycycline and minocycline for the management of acne. And also, there's no data really on the cost effectiveness. While what is a low-cost antibiotic, we have to think about other costs in terms of potential side effects and negative impact as well. So we are moving toward having a database that WHO might need in terms of evidence. So I've shared with you the data on the two efficacy trials. There are additional efficacy trials being conducted now in British Columbia. And also we will see the additional data from the IPRIGAE study. Safety, I would say, the long-term, we've had tetracyclines available since 1957 and doxycycline for decades as well. I think the safety data is actually quite robust. Cost effectiveness, we need to do some more work. Feasibility, I think we demonstrated it is feasible. Acceptability, I would say we need to replicate those studies in other populations outside of Australia, online populations of heterosexual men. Equity, I would argue that it's inexpensive, it's highly accessible, it's included on essential medication lists, but there's still some room for further research to understand the values and preferences, particularly among the target population and among providers. So our next steps are to continue to conduct implementation studies with resistance monitoring, to do cost effectiveness studies, to do more modeling studies in the target population, and additional studies on acceptability and values. So thank you very much, and I want to thank the various co-authors and co-investigators who have worked with us in this area for probably about 8 years now. Thank you.
At the end, it's my pleasure to introduce David Regan. David Regan is a colleague and a mathematical modeller at the Kirby Institute. Actually, David's not actually going to be here, but he has kindly recorded his slides, so you'll hear his voice. He's a very nice-looking chap, so you can just imagine a nice chap standing here and speaking, but you won't actually see him, you'll only hear him. So we have tested this and it has worked, so we're going to keep our fingers crossed that in a minute.
Good morning, everyone. I'm disappointed that I can't be with you in person today, but delighted that the organisers have allowed me to share my thoughts on this topic with you from afar. Thanks also to Kit Fairley for agreeing to field your questions during the discussion that is to follow. So today, I'm going to outline why I think vaccines are important for STI control among men who have sex with men, briefly discuss immunisation thresholds, and then talk about the vaccines we currently have and what the prospects and priorities are for future vaccines. So let's begin with why vaccines are important. We're being told that men who have sex with men are throwing away their condoms as a consequence of biomedical interventions such as pre-exposure prophylaxis for HIV prevention. While the extent to which this is happening and the link between these phenomena is perhaps still being debated, there is no question that STI rates have increased dramatically in MSM populations in most high-income settings in recent years, equaling or surpassing pre-HIV levels in some cases. There is also substantial evidence that STIs facilitate HIV transmission and that HIV-positive men are at higher risk of HPV-related cancers. And antimicrobial resistance is threatening our ability to treat some STIs, gonorrhea and Mycoplasma genitalium in particular. So vaccines, the ones we have and the ones we would like to have, are a potentially powerful weapon for STI prevention as an adjunct to other preventative measures and treatment. So what are the advantages of vaccines? It could be said that vaccines are the holy grail of infectious disease prevention. The availability of an effective vaccine combined with adequate uptake can lead to substantial reductions in the prevalence of infection and even elimination under certain circumstances. When a portion of the population is immunised, those not vaccinated benefit indirectly through herd protection. Vaccinated individuals may be able to forego other measures for avoiding infection, such as the need to use condoms. And, as I already alluded to, the availability of a vaccine may compensate for increased risks associated with behavioural shifts accompanying the uptake of biomedical interventions for HIV. There are, of course, some caveats. The development of effective vaccines for bacterial STIs and HIV has proven extremely challenging. The effectiveness of vaccination at a population level depends on uptake, which in turn will be determined by other factors such as the perceived risk of infection, the severity of symptoms and sequelae, and the cost of the vaccine if not freely available. Vaccines may also confer a false sense of security in those who have been vaccinated. Vaccination against one STI does not protect against infection with other STIs, and unless the vaccine is 100% effective, there is still a risk of acquiring infection if other preventative measures are not taken. I'd now like to talk briefly about immunisation thresholds. This is a topic originally suggested to me for this symposium, but I felt it needed to be placed in a broader context. So what do I mean by immunisation threshold? This is sometimes referred to as the herd immunity or herd protection threshold. I think that's somewhat misleading, but that's for another discussion. What I'm referring to for the purposes of this discussion is the proportion of a population that must be vaccinated against an infection such that sustained transmission of that infection can no longer occur in that population. The main reason why this is worthy of discussion is that an immunisation threshold, if it can be established, sets an aspirational target for vaccination coverage. And I'm going to begin this discussion by introducing the notion of the basic reproduction number, affectionately known as R0, which I'm sure many or perhaps most of you are familiar with. The basic reproduction number is defined as the average number of secondary infections caused by a typical infectious person when that person is introduced to a wholly susceptible population. Knowledge of R0 provides us with a measure of how effectively an infection will spread in a population. That is, how likely it is to spread and the speed and scale of spread. R0, in fact, denotes a threshold. If it takes a value greater than 1 for a particular infection and population, the infection is likely to take hold. Whereas, if it takes a value less than 1, the infection is likely to die out. Ideally, then, we want our interventions to have the effect of reducing R0 below 1. There are many ways of calculating or estimating R0, but it is often expressed in the form of the equation given here, an equation that I'm sure many of you are also familiar with. This equation states that R0 for a particular infection and population is equal to the product of the length of time an individual is typically infectious, the number of contacts an individual has during that time, which in the case of an STI is the number of sexual contacts, and the per contact probability that transmission will occur. Now, each of these terms will vary depending on the affected population, and thus the value of R0 for a given infection will vary depending on the population. Under each of these terms, I've listed some of the factors that contribute to this variability. Those in italics do not strictly apply to R0 because they are related to control and prevention in an already exposed population rather than a naive population. More correctly, these would modify what we refer to as the effective reproduction number. In the context of vaccination, it is useful to know R0 because this enables us to estimate the proportion of the population that must be immune in order that sustained transmission cannot occur. It's not necessary to vaccinate 100% of the population to achieve this. It's only necessary to ensure that effective reproduction number is less than 1. The critical proportion of the population that must be immune to achieve this is given by the equation shown here. For example, if R0 is known to be 2, we know that we must ensure that 50% of the population is immune, whereas if R0 is equal to 10, 90% of the population must be immune. Knowing R0 is useful, therefore, for informing aspirational vaccination targets. But that's not to say that vaccination is not useful or desirable if elimination can't be achieved. However, whereas for some common immunizing infectious diseases such as measles, R0 can be estimated relatively easily from epidemiological data such as age-specific seroprevalence and age at infection, it is generally much more difficult to estimate R0 for STIs. Transmission networks are complex and transmission is difficult to directly observe. We can, however, estimate R0 for STIs using mathematical models, but the reliability of these estimates really depend on the quality and completeness of the data being used to inform the models. And as I've already stressed, the value of R0 for a given STI is determined by the unique characteristics of the affected population. This table is taken from the Wikipedia entry for R0 and gives some indicative values of R0 for a range of diseases. The reason for showing this is to illustrate that there is considerable variability in R0 values between diseases, and a range of values is given for each individual disease. These ranges reflect both the inherent uncertainty in estimating R0 and the variability attributable to different populations. I'd also like you to note that sexual contact is given as the mode of transmission for only one of the diseases listed here, namely HIV. So I spent considerable time scouring the literature to find estimates of other key STIs that affect men who have sex with men. This was by no means a systematic search, but the results are nonetheless informative, I think. In particular, there are 3 points to be made here. Firstly, there is considerable variability in the estimates. This should not be surprising given what I've already said about the source of this variability. Secondly, I could not find any estimates of R0 for some STIs. That's not to say they don't exist. And thirdly, there appears to be a real paucity of information in regard to R0 for STIs in populations of men who have sex with men. To summarise all this, we have estimates of R0 for many non-sexually transmitted diseases and for several STIs in the context of heterosexual populations, but very few estimates for MSM populations. The estimates we do have for MSM suggest that 70% or more of the population must be vaccinated or immune to eliminate infection or make sustained transmission impossible. But as I've already mentioned, vaccines can play an important role in STI prevention, even if elimination is not possible. And here I'd like to present as an example a study by Craig and co-workers that used modelling to explore the potential impact of a theoretical vaccine on gonorrhea prevalence in a general heterosexual population. In this study, a number of scenarios were examined, including a range of vaccine efficacies and a range of durations of protection. The results of this study suggest that gonorrhea prevalence could potentially be reduced by 90% if all 13-year-olds are vaccinated, and either the vaccine is 50% efficacious and confers lifelong protection, or the vaccine is 100% efficacious and protection wanes after 7.5 years. Obviously, these are just two of any number of possible scenarios. The model also suggests that prevalence could be reduced by 40% if all 13-year-olds are vaccinated. The vaccine is only 20% efficacious but provides lifelong protection. What this modelling work tells us is that a vaccine of only moderate efficacy could potentially have a substantive impact on gonorrhea prevalence and sequelae. But we must keep in mind here that R0 is almost certainly higher for MSM populations, and so higher vaccine coverage will be required to achieve the same impact. I'd like to move on now and talk about where things currently stand with vaccines for STIs and what the prospects are for future vaccines. I'll start with HIV. In 2015, there were 17 million HIV-infected people on antiretroviral therapy worldwide, but an estimated 6,000 new infections were being acquired every day. So the quest for an HIV vaccine remains a global priority. Unfortunately, developing an effective vaccine for HIV has proven extremely difficult. 6 vaccine efficacy trials were conducted between 1987 and 2013, and all but one of these failed. The RV144 vaccine trial in Thailand showed modest protective efficacy of around 30%, but this was not considered sufficient for vaccine development. Despite these failures, research is ongoing, including a follow-up trial to the RV144 trial in men who have sex with men in Thailand. But because of the lack of success in developing an effective vaccine, there has been increased focus in recent years on biomedical interventions for HIV prevention, including treatment as prevention and pre- and post-exposure prophylaxis. For hepatitis B, we've had an effective and long-lasting vaccine since the early 80s. This vaccine is normally administered in the first year of life as a 3-dose regimen. As of 2015, routine infant vaccination has been introduced in 184 countries, and it is estimated that 3-dose coverage of newborns had reached 84% globally. However, immunisation coverage in adults is generally much lower. In the US, for example, 3-dose coverage of adults was estimated to be only around 25% in 2014, and a little higher among high-risk groups, including MSM. On the upside, adults are much less likely than infants to develop chronic infection that can lead to liver disease. Men who have sex with men are at higher risk of hepatitis B infection, yet a survey conducted among young men in the US between 1998 and 2000 estimated immunisation prevalence to be only around 17%. So I think it's fair to say that a large proportion of MSM in many settings remain at risk of hepatitis B infection despite the availability of an effective vaccine. Turning to hepatitis A now, we've also had an effective and long-lasting vaccine for this infection since the early 90s. 1 or 2 doses of an inactivated hepatitis A vaccine is the recommended regimen. But as of 2016, only 16 countries have introduced routine childhood vaccination. It is thought that in general, countries of intermediate endemicity will benefit most from routine childhood vaccination. Taking my home country Australia as an example now, hepatitis A vaccination is provided free to Indigenous children who are at high risk of infection, and is recommended but not free for others at high risk, including men who have sex with men, intravenous drug users, and people travelling to countries where hepatitis A is endemic. In modelling work conducted in my group, we used data from a large outbreak of hepatitis A among MSM in Sydney in 1991-92 to estimate R0 and the critical immunisation threshold. We estimated R0 for this population to be about 3.3, and thus the level of immunity required to prevent sustained transmission or future outbreaks to be about 70%. In a separate study of attendees of a major sexual health centre in Sydney, we estimated hepatitis A seropositivity among MSM to be 60 to 65%, suggesting that the current level of immunity in this population may be insufficient to prevent future major outbreaks. Finally, there have been several reports of hepatitis A outbreaks among MSM in low endemicity countries in recent years, including England, Germany, Spain, and Taiwan. More recently, highly effective and probably long-lasting vaccines have become available for HPV. While it will be a decade or so before we know the true impact of these vaccines on cancer, we are already seeing strong evidence of reductions in genital warts and pre-cancer attributable to HPV. We're also seeing evidence of herd protection amongst those not vaccinated. HPV is now included in the national immunisation schedules of 70 countries, but full 3-dose coverage remains low in many settings. HPV vaccination is provided free to boys and to vulnerable groups of men, including men who have sex with men, in only a small number of countries and provinces. The arguments for male HPV vaccination include equity, stronger herd protection, the higher risk of infection among some population subgroups, including MSM, and cost effectiveness. Taking Australia as an example again, modelling work conducted in my group suggests that at current coverage of gender-neutral vaccination, genital warts may be eliminated in Australia. However, this study didn't account for men who have sex with men, among whom R0 is likely to be higher. And finally, results of a recent meta-analysis of HPV modelling studies suggest that elimination of HPV 6, 11, 16 and 18 may be possible with 80% coverage of gender-neutral vaccination. Again, however, none of the studies included in this analysis considered populations of men who have sex with men. We don't currently have a gonorrhea vaccine, but as I've already mentioned, this is a priority in the face of expanding antimicrobial resistance and the threat that gonorrhea may become untreatable. The WHO has declared this to be an urgent global threat, and the US CDC have classified Neisseria gonorrhoeae as an urgent resistance threat, one of only 3 bacteria to be classified at this level of threat. Even if new drugs are developed, these are likely to provide only a temporary solution to the problem, given this organism's propensity to acquire resistance. A vaccine, therefore, may be the only long-term solution for gonorrhea prevention and control. There are, however, currently no gonorrhea vaccines in clinical trial. 4 vaccine candidates have progressed to clinical trial, all prior to 1990, and none of these were successful. Despite this, research is ongoing, and advances in the last few decades suggest a vaccine is feasible, but this will require a concerted effort to fill the gaps in our understanding of the host-pathogen interaction and to establish a reliable correlate of protection. So I've talked about the vaccines we do have for STIs and the one we don't have for gonorrhea. So where are we then in regard to vaccines for other STIs? Other than for HIV, herpes is the only other STI for which, to my knowledge, clinical trials are currently underway, and these mostly focus on reducing recurrence and shedding rather than directly preventing infection. For chlamydia, this is an active area of research, and there is the prospect of phase 1 trials in the coming years. Vaccine development is also an active area of research for trichomoniasis, but while several animal models have been developed, research has been hindered by a lack of public interest, and there are currently no promising vaccine candidates. Syphilis vaccine research is limited worldwide, and there are currently no promising vaccine candidates for this infection either. Vaccine development for MG is currently not an active area of research, but this may change in the coming years as treatment for this emerging pathogen comes under threat from antimicrobial resistance, mirroring what we are currently facing with gonorrhea. In conclusion, I'd like to make the following points. Given the continued scale and burden of the HIV epidemic, the pursuit of an effective HIV vaccine must remain a global priority. A vaccine for gonorrhea is also a priority given the threat posed by antimicrobial resistance and the possibility that this infection may become untreatable in the near future. There is scope to improve the uptake of vaccines that are currently available through enhanced promotion, subsidisation of cost, and targeted programs. This applies in particular to hepatitis A and B, and targeted HP vaccination programs, MSM, should be given consideration in settings that currently only have female vaccination. Development of vaccines for other STIs will require a concerted and coordinated international effort, and the impetus for this will be driven by a number of factors, including the perceived seriousness of symptoms and sequelae, the degree to which current treatments are threatened by antimicrobial resistance, the likely efficacy of vaccines, and consideration of cost effectiveness. This slide and the following slide list references for R0 estimates I presented for the various STIs. And that's it from me. Thank you for your attention.
Clap or not, but I will take that message home from me that we clapped. So So now we're going to hear from Henry de Vries from the University of Amsterdam, who's going to talk about risk compensation in men who have sex with men in the area of biomedical non-condom-based interventions. And we're going to have all the questions at the end. Thank you, Henry.
Thank you, Kit. Okay, this talk is an excerpt of the section in the commission, the Lancet ID Commission, which was launched yesterday. Here you see the title. It has been known for long that male homosexual activity is a strong risk factor for STI. And I'm very grateful for the excellent talk of the previous speaker for explaining the reproductive number equation, because there are some biological explanations for the strong risk factors of male sex. Higher number of sexual partners are often the case, and also anorectal sex might expose and also lead to increased transmission possibilities for pathogens. But apart from the biological explanation, there are also sociological explanations like ignorance and myths around male-male sexual contact. The fact that barrier protection isn't required for contraceptive reasons, and of course social explanations like illegality, homophobia and stigmatization, which discourage the formation of stable relationships. And last but not least, which is a very relevant subject today, is the use of disinhibiting substances, which is frequented by high-risk MSM today, and is also known as chemsex use. To depict that we really dealing with a completely different network in MSM and the STI circulating there, you see here a genomic fingerprinting study we have performed in Amsterdam, where you see with MLST, multi-locus sequencing typing, we fingerprinted chlamydia strains found in MSM as opposed to heterosexual men and heterosexual women. The pink dots are the strains we found in men who have sex with men, and the larger the circles, the more strains with an identical fingerprint were found. And if there was only one locus difference, then we consider it a cluster, and there is like a watershed in the strains that are found in MSM as opposed to the strains that we find in heterosexual clients of the STI clinic. It's like almost 100% difference, and the strains do not circulate across these groups with sexual preferences, different sexual preferences. This is also reflected in the epidemiological curve, and this is an epidemiological curve from England and Wales of the past 65 years, but the same patterns are seen in the United States. This was seen in the keynote lecture of colleague de Kock on the first day of this conference, where you see the male to female ratio depicted in the green line in new diagnosis of syphilis. And you see that in the 1950s it was about 2, so already twice as much males were infected with syphilis as opposed to women, but it was increasing up until the moment of the advent of HIV and AIDS, and then it decreased again to 2. And since 2000 we see an incremental increase in the number of infections, and the far majority occur in men who have sex with men, and just very little, few infections are found in the heterosexual population. And that's what you see here, again, epidemiological data from England, where you see that not only syphilis, but also gonorrhea and chlamydia are incrementally increasing. And if you compare it with the epidemiological curve of HIV infections, you see that there is a decoupling. What we see in the bacterial infection is not the case in HIV infection, which is rather stable. And actually, at the moment, we see even a decrease in the number of new HIV infections. It was recently reported that there's a 40% decrease in new HIV infections found in London in the last year. And I'll come back to that later. So what we were looking at the use of antiretroviral drugs used for the treatment of HIV, but then from a more prophylactic aspect, post-exposure prophylaxis, which has been around for 20 or somewhat years, treatment as prevention, start treating not based on the CD4 count any longer of HIV positive individuals, but to treat them irrespective of the CD4 count to prevent them from being infectious further on. And then pre-exposure prophylaxis dedicated to HIV negative men to prevent them from becoming HIV infection. And there has been a concern about possible unintended negative consequences on sexual risk behavior and also an STI increase because these men would start to use condoms less frequently, possibly have more partners, and that's what's called risk compensation. HIV optimism is probably something else which could attribute to the introduction of combination antiretroviral therapy, and that's the same for safer sex, fatigue, and sero-sorting, where men, based on their sero status, seek partners with the same sero status and then assume that they do not have to use condoms because the perceived risk to become HIV infectious is decreased. It has been in the media in the beginning when PrEP was first on a broader scale published and also promoted that it has a bad image, which was also called men who used PrEP or Truvada, as the brand name is called, were designated Truvada whores as being very irresponsible, just wanting to get rid of condoms and have sex with as many partners and just don't care about getting HIV infected. You can see what spinning can do because the next action which was taken was to turn Truvada horse into Truvada hero, that men who are taking PrEP are taking responsibility not only for their own health but also for the health of their partners, and that has been very effective. This whole controversy isn't new. This was also pointed out in the plenary lecture yesterday, that we have seen the same thing with oral anti-contraceptives and the perceived effect on promiscuity among women who use anti-contraceptives. And this is a beautiful publication from The Lancet in 1964, when it was first introduced as estrogen preparation to prevent to become pregnant. And the author quotes one of his colleagues who says that modern girls at the age of 15, they do not have the experience to use oral contraceptives in a proper way, as opposed to a woman of 30 who would do it, who would use it in a proper way. And the response of this author says that young people can easily obtain mechanical and chemical contraceptives, but there was absolutely no evidence that increase in promiscuity resulted from this. This is 1964, but it took up until 1999 before in Japan oral contraceptives were legalized, the use of oral contraceptives. And here you see a publication of 1992, but it took another 7 years before the ban on birth control pills was lifted in Japan. And the fear from the government was that these pills would discourage the use of condoms and lead to an epidemic of AIDS. So what do we know about whether these biomedical interventions do increase risk behavior? This is data from Australia, with thanks to Kit Fairley, of the use of condoms during anal sex among men who have sex with men. And you see in the dotted line that the not always using condoms increasing, and always using condoms has been decreasing in the past 20 years. And also having sex and not having anal intercourse is also increasing. So it looks like in the last 30 or 20 years there has been increasing risk behavior if you look at these proxies, at least in Australia. So first of all, what has been the effect of PEP on risk compensation? PEP has been proved effective after percutaneous exposure, not after sex incidents per se, but based on these results, it was assumed that it could also help after a sex incident to seroconvert. And some studies have been performed, some of them also in Amsterdam, and it was found that more non-condom sex and a higher incidence of HIV was found in men who had received post-exposure prophylaxis. So they did turn seropositive after 6 months or so or later, although the PEP had assumed to have been working at the moment the sex incidents had taken place, but they insisted on having unsafe sex and then became HIV infected later on. There was no correlation between PEP use and changes, at least in risky behavior. There have been risk behavior before using PEP in these men, and this just continued afterwards also. The only problem is that PEP has a lot of limitations, so it's very unlikely that it will have an effect on sexual risk behavior and STI on a population level. Then treatment as prevention, to prevent HIV transmission. In the HPTN 52 landmark study, it was clearly shown that in HIV serodiscordant couple, HIV transmission could be reduced by 96%. And the Swiss were even ahead of these findings and already stated that serodiscordant couples could have non-condom sex if the HIV positive partner was virally suppressed. What is known about risk compensation attributing to treatment as prevention? There was no effect on STI incidence in the HPTN 52 study, but the problem is that this was a study mainly in heterosexual couples, and there is little evidence on what treatment as prevention has resulted in sexual risk behavior in men who have sex with men. We did have some circumstantial evidence, though, and that's thanks to the data provided by the City Clinic of San Francisco, where we have assembled STI positivity and also HIV incidents since 2005, and treatment as prevention was introduced in San Francisco at the end of 2009. But what you see is that HIV was already decreasing before treatment as prevention was introduced, and also early syphilis was already on the rise before treatment as prevention was introduced. So clearly there is no direct relation between the moment treatment as prevention was introduced in San Francisco. We did see some bend in the curve for gonorrhea, for example. It was decreasing and then it was slightly increasing, but it is not significant. And this is also the case for mean number of sex partners, which you see in the yellow dotted line underneath. Back again to the data from England. I also showed you this slide before. You see the introduction dates of combination ART, pre-exposure prophylaxis, treatment as prevention, and lastly the PROUD results who became available, and on a limited scale PrEP is now available in the UK. And also here you see that the increase of STI is preceding the date of these introduction of these different biomedical interventions. So again, no circumstantial evidence, at least no epidemiological evidence that supports the idea that risk compensation is occurring due to pre-exposure prophylaxis availability. PrEP is effective. It's been already told a lot of times. Up until 96% of infections can be prevented in HIV negative MSM. And some studies have been performed. The thing is that the guys who get PrEP at this moment, they all have a high risk for STI based on the inclusion criteria of the trials. As you can see here, recent rectal and urethral STIs, recent use of PrEP, intercourse with casual partners, and having an HIV partner with a detectable load. The placebo-controlled studies are very hard to judge on the effect of possible risk compensation because of the blinded nature of these studies. PROUD was an open label study where one group was put immediately on PrEP and the other group had to wait for a few months before they were put on PrEP. And there was no difference in STI found between the immediate and the deferred arm of this study, although it was seen that non-condom preservative anal sex with 10 or more partners was significantly more often the case in the group who got immediately PrEP as opposed to the deferred group. The demo project, which was also an open and more real-life designed study performed in several studies in the United States, also looked at risk behavior, and you see that the overall number of non-condom preservative anal sex in the gray bars was stable throughout the 48 duration of this study, although the mean percentage of condom protective sexual acts did decrease, which you see here in the gray line. The incidence of bacterial infections, first of all, dropped, and halfway the study, it returned again to baseline values. So again, no evidence that PrEP did induce risk compensation as far as STI increase. And it was concluded in another paper that men seem to integrate PrEP in a dynamic way into existing risk reduction strategies rather than relying on it as a solitary method of HIV prevention. So what will the future bring as far as PrEP, which is a very important and also considered disruptive intervention in relation to risk compensation? We have limited data as far as the time, 1 to 2 year follow-up. So we need absolutely data on longer follow-up studies. There are some mixed effects on sexual behavior, as I've shown you, and what the long-term effect on risk compensation will be is not yet known. It's especially a challenge if PrEP will be used by lower risk compensations, by lower risk population. What will happen in this group when they stop using condoms, for example? It's of interest, a new name was coined, biomed matching, which is seen now online, where men who disclose the use of antiretroviral therapy, either as PrEP or as therapy for, when they're HIV infections, but they seek partners based on using the use of antiretroviral drugs. So to conclude, trends in HIV infection and other STIs seem to have decoupled. STI rates in MSM have been increasing since the late 1990s. And in London, we see a reduction of HIV now by 40% in the past 2 years. Of course, you have to take some limitations because this could be a true increase, but it could also be due to more frequent testing, because that's what's happening now when people are put on PrEP. Biomedical interventions will affect sexual networks and also STI patterns. It will probably lead to more bridging, as I just showed you, by biomed matching between HIV positive and HIV negative MSM, and that could lead to outbreaks. We've seen now a 5% hepatitis C positivity in men who seek pre-exposure prophylaxis in Amsterdam, and the same could occur for LGV, for example, what is now seen mostly in HIV positive men who have sex with men. STIs could increase HIV infectiousness. That could be a threat because it could reduce the effect of these biomedical interventions. And the big question, of course, is how are we going to communicate and advocate condom use in the age of these biomedical interventions available. And lastly, biomedical HIV infections also can have a positive role in STI control because men on PrEP need to be checked every 3 months, not only their HIV status, it's recommended, but also other bacterial STIs. And that's an opportunity for better management of STI in these high-risk groups. I'd like to acknowledge the other co-authors who contributed to this part of the section, and I have a little more time to draw your attention to two very interesting conferences and courses that will be held in Amsterdam. First of all, there's an anoscopy course if you are interested in anal cancers and the prevention of anal cancer by high-resolution anoscopy. We have a beautiful course both for basic and advanced practitioners with live streaming demonstrations of high-resolution anoscopy in November of this year, and you can register online via anoscopycourse.eu. And then the International Chlamydia Conference, Human Chlamydia Infections Symposium, which will be held back-to-back with the Dublin World IUSTI meeting in 2018. So you can combine this trip and make your visit to Europe of more value. Thank you for your attention, and I'm happy to take questions.
So thank you for 3 excellent talks. Now I'd like to invite all 3 up onto the podium here. We've got about 12 minutes for questions. So if you'd like to come to the microphone, if you've got any questions you'd like to ask. So while you're thinking of some questions, I will start with one. Henry, you showed that graph of changes in anal intercourse that really wasn't very impressive. It hadn't changed very much. Yet the graphs you showed of some of the changes in STIs were really impressive. What exact sexual practices are responsible for those big rises?
You mean for the bacterial infections? Yeah. I think it's anal sex. But also oral sex could be of importance for the spread of gonorrhea, for example, and LGV, although this is still hypothetical. But I think, first of all, genital anal sex is probably of most important.
Okay, so we'll come back to that if we run out of questions from the audience. So Andrew Grulich from the Kirby Institute.
Thanks, Kit. I just wanted to make a point about all of the data we're hearing on risk changes in gay men on PrEP, and it's just to say that I think it's really early to be making conclusions because all the studies thus far have been small, but we are moving very quickly to much larger studies, and I think it's going to be very different. There has been some consistency, though, in decreased condom use, no change in partner numbers, but decreases in condom use, and I can just update the graph you showed from Sydney with our data from February of this year. We now have almost 6,000 men on PrEP in the state of New South Wales, and we are seeing very large increases in condomless anal intercourse. So I think it's time for us to get ready for it, to ensure that we integrate STI testing, regular STI testing into our PrEP schemes.
No, I fully agree. It's too early to do to draw hard conclusions. What I also find of interest is the decoupling that we see. So men already know for a long time how to protect themselves for HIV, whether it's serosorting. It's not clear, but you already see an increase of STIs among high-risk MSM. And what will happen if PrEP will be used by lower-risk MSM? That's really the question out. I think, though, that the people who use PrEP at the moment, they are already on a max of the incidence of bacterial STI at the moment, and possibly they cannot even go higher. So that could explain why we do not see an effect at the moment.
And before we go on to Matthew, Jeffrey, you had something you wanted to say?
Yeah, I just had a comment on the vaccine discussion. So David, he didn't have the information to present the report in the Lancet yesterday about the estimate of efficacy of the meningitis B vaccine for Neisseria gonorrhea was reported 31% in the New Zealand epidemiologic study. And I was just kind of curious on your thought or other thoughts about whether 31% efficacy would be sufficient to justify implementation. And based on his modeling, 31% efficacy, if you did have uptake of 50% in a at-risk population would be sufficient to bend the curve of increased gonorrhea incidence.
So I'm channeling David now. I'm trying to answer his question. So I would say he would probably say this. He'd say that in heterosexuals, if you have good access to healthcare, it's probably almost no need for the vaccine. In countries that don't have access to healthcare, it might well be enough, as you suggest. And in MSM, I think he'd probably say it won't be quite enough. But it's a great paper from New Zealand. I couldn't agree more.
So we say that again, that in heterosexuals with good access to healthcare, you don't think it would be justified, but in heterosexual men, it would be?
So in heterosexuals that have good access to healthcare, the Scandinavian countries and so forth, and in Australia, we don't see a huge amount of heterosexual gonorrhea. So you're going to have to vaccinate a lot of people for a 30% benefit. But that's not the case in some countries where access to healthcare is not ideal and may get worse. But in MSM, one wonders, seeing the gradient of that curve, whether that vaccine would be sufficient. But others may want to comment on that. And now we'll go to Matthew Golden from the University of Washington.
So I had one comment and a question for Henry. We've been tracking serosorting behaviors in our STD clinic in Seattle since 2003. And what we've seen is that serosorting peaked around 2015 and has since started to decline, suggesting that there's a change in the mixing patterns within the population, which is potentially consistent with the movement of syphilis from a high-risk population of predominantly HIV-positive men who have sex with men, increasingly into what was traditionally a lower-risk population of HIV-negative MSM and an explosion of our syphilis epidemic. So I actually do think we've been seeing some more complex changes in sexual behaviors, at least where I live. And I guess what I'd ask you is, the change in sexual behaviors that you see as we introduce the new interventions can affect the individuals who use the new interventions, but they can also induce a larger ecological effect in the population as a whole. So it's not just that the PrEP users change their behavior, it's that for whatever reason, norms change in the population, or seems to, and I'm interested in your thoughts on that.
Mm-hmm. Yep, that could very well be the case, and that's what is also mentioned as HIV optimism. It's not considered a very serious infection any longer, and PrEP could attribute to that. But then it's also interesting to look at history, what happened with oral contraceptives, where, yes, these are, again, disruptive developments, and the future will tell how it will be picked up and what the effect on the society at large will be.
So we're going to take one question from the floor and then come to Mariangela.
Thanks. Christina Schumacher, Johns Hopkins. I just want to piggyback on Matt's comment. And I think we've been very focused on data for individuals on PrEP and what their behavioral compensation may or may not be. And I think we need a much broader picture of what's going on in the population as a whole, especially as we're not sure quite yet in various places in the US and elsewhere we're getting the key people on PrEP to begin with, and also what's happening with the network. So as serosorting declines, we're broadening our network, it's more diffuse, and I think it's just, there's a potential for an explosion, continued explosion of syphilis and gonorrhea, and I think we need to broaden our focus to really understand the total picture rather than just what happens when you put someone on PrEP.
Mm-hmm. No, I agree. But then I also think that just the introduction of combination antiretroviral therapy already had this change in perception about becoming HIV infected. So what the added effect of PrEP on the population will be, yes, I'm looking forward to find out
Okay, Mariangela.
Oh, I have a question for David. So we can
David. Okay, I'll get him on the line again.
So, when you see the coverage for, we are talking about MSM and teens, especially young MSM. When you see the coverage for B hepatitis, for the vaccines that already exist as B hepatitis and A hepatitis, what are the strategies that you think that are going to work? Because you see very low coverage in very well-developed countries and B hepatitis among young teenagers. So what do you think about that? How do you should improve that?
So David would say that about hepatitis A, first of all, let's say when the epidemics occurred, I think the coverage was about 40% in Melbourne and Sydney, and has been pushed up to about 50 to 60%, and we haven't seen any more. I'd be interested if Glenda's here or anyone else from the London or elsewhere where the hepatitis A outbreaks have been, what coverage that you get in your MSM population. Having said that, as sexual practices change, the coverage may well have to go up higher than 70% with the basic reproductive rate that David showed of about 3, because of course as sexual practices change, the C changes in the equation, and so the proportion need to vaccinate to prevent an epidemic will go higher. If there's anyone in the audience who can comment on the hepatitis B, I've just lost connection with David on that particular one at this point in time.
I'll make a comment. I mean, I think your question was how to achieve higher levels of population coverage. So at least with hepatitis B, in 1991, in the United States, they introduced it as routine infant vaccination. So now 26 years later, you have a highly vaccinated cohort. So I think, we have to take a public health approach of structural interventions, and the state of California right now 10 vaccines are required for entry into kindergarten, and then additional vaccines are required for entry into 7th grade, and these school entry requirements, while hotly debated by a very small but vocal group of anti-vaxxers, are highly effective ways to achieve high levels of population vaccine coverage.
Yes, for the catch-up.
I also have a question for Jeff. Jeff, you only mentioned doxycycline as a prophylactic for bacterial STIs. Could you comment on other options, azithromycin, for example, and what the benefits or the disadvantages could be of other antibiotics?
Yeah, and I think, azithromycin being a long-acting antibiotic with a 68-hour half-life, could be considered on a less frequent than daily basis. I think the obvious concern is resistance caused and associated with azithromycin. So Sheila Lukart and I had, reported in 2004 the rapid introduction and rise of azithromycin, treponema pallidum, syphilis infections that was associated with azithromycin exposure. You have increasing azithromycin resistance in Neisseria gonorrhea. So that would not be one. For whatever reasons, we haven't seen doxycycline resistance in T. pallidum. It might not be associated with a viable organism. I was speaking to Patty Horner last night, and he is concerned about doxycycline resistance in chlamydia. It's been reported in chlamydia suis, which is endemic in pigs. Pigs have a high exposure to tetracycline. We have not seen that yet in chlamydia trachomatis, but there would be a concern. It should be monitored in any kind of program where we did roll out bacterial prophylaxis. Okay, so we're going to take one last question, then Mariangela has something to say.
I just wanted to make a point about vaccination rates. It's becoming fairly clear around the world that the countries with highest rates of vaccination for human papillomavirus and other sexually transmitted infections are doing it in schools. Not always, there are some exceptions, but I think if we do happily find an effective chlamydia vaccine, for example, which is predominantly we're concerned about infection in young women in the general population, then schools would be the place to give it. And maybe we as a sector who work in STIs need to start thinking about schools as a place to deliver vaccinations.
Thank you.
Okay. Thank you very much for all the presenters and for you to be here with us. And as a reminder, the organizer remind that we have a carnival ball tonight, and you can register at the registration booth at the ground floor. And the bus will leave the hotel for the carnival at 7 p.m. Thank you very much.
No, mine's